Welcome. My name is Laura Zatella. I'm a nurse practitioner at the University of California, San Francisco, and we are coming to you virtually from ASH 2023. I am delighted to have Dr. Clare Sun join us. She is an associate research physician at the NIH, and she presented an abstract looking at clonal evolution and mutations for the use of Acalabrutinib to treat CLL. Welcome, Dr. Sun.
Hi, Laura. I'm happy to be here to share my research.
So we know that BTK inhibitors, such as Acalabrutinib, are a really important treatment tool for people who have CLL, but unfortunately, mutations can develop over time that cause the drug to lose effectiveness. Can you tell us a little bit about the research that you presented?
Yes, so at the NIH, we have a single agent acalabrutinib study that's been ongoing since 2015. And so in this abstract at ASH, what we wanted to provide was an update on the long-term follow-up of our patients, as well as describe some of the shifts in mutations that we're seeing in patients who have been on it for long-term, as well as those who develop progression. So in total, the study enrolled 48 patients, and we have a follow-up now of 6.5 years. So quite long. And at 6.5 years, we were able to finally find the progression-free survival median of 6 years. And overall, out of 48 patients, 23 have progressed, including 20 with CLL, and then 3 earlier on with Richter transformation. So this was an effort that we took from the very beginning, collecting regular blood samples from our patients on treatment and then at the time when they develop progressive disease. So in total, we sequenced 241 samples from our patients. And that started at the time they began treatment with acalabrutinib at 6 months, and then continued yearly until they developed progressive disease. And then at that time, we would sequence them again. And where possible, we always try to obtain either paired bone marrow or lymph node samples at progression as well, because we believe that some of the progression events are actually compartmentalized, meaning they affect one location more than the other. So we had some of those samples sequenced as well. And our main questions were there any baseline features that seemed to enrich for progression? Did any new mutations come up during the course of treatment that would influence the outcome? And finally, what did the mutation landscape look like when patients develop resistance to therapy? So those were kind of the key questions we wanted to address in our current abstract. So the study itself, the patients who were eligible either had relapsed refractory disease or high-risk treatment-naive CLL. And we defined high risk here as patients with deletion 17p, p53 mutations, or Notch1 mutations. So really this group was high risk considering that they were either previously treated or had these adverse molecular features. And with that being said, over 90% of our patients had mutations in what we consider CLL driver genes, even before they started treatment. So these are genes that we think are involved in CLL biology, might drive how aggressive they are. So most of our patients already had, some mutations in these genes before they even started. And then during the course of treatment, while they were still in remission, patients continued to develop new mutations in these driver genes. And approximately 40% of patients were found to have new mutations as while they were still in remission, continuing to respond. But I think kind of reflecting the adaptive nature of the CLL. But interestingly enough, none of the genes that became newly mutated during treatment really affected the final outcome, which was progression. And then at the time of progression, we were able to sequence all 20 patients who had actually progressed with CLL. And what we found was that 80% of patients did have, new mutations in what we consider driver genes, most commonly being BTK and PLCG2. And that's not too surprising because of what we know about ibrutinib. Those are also the two most commonly mutated genes when patients develop resistance to ibrutinib. And we're seeing a similar frequency with acalabrutinib in this study. The interesting thing to note, though, is that the actual BTK mutations were a little bit different than what we have typically seen with ibrutinib. So at the time of progressive disease, 55% of patients, so a little more than half, had mutations in the BTK gene. And whenever it was mutated, the C481 residue, which is the residue that the acalabrutinib binds to, that was always mutated. But in addition, 20% of patients actually also had the T474I mutation, and that occurs much more rarely in patients treated with ibrutinib. So it was a new finding. And then there was also PLCG2 that was mutated in a quarter of patients. Sometimes this would occur in patients who had no mutations in BTK. At other times, it would co-occur. So I wasn't too clear whether, the PLCG2 was necessary in all cases. I had mentioned that we also try to sample the bone marrow and lymph node as well, where possible. And we were able to look at the frequency of the BTK mutations in that setting, comparing the blood to either bone marrow and lymph node. It did seem like the frequency of the mutation were better correlated with bone marrow, but in lymph node, there seemed to be more discrepancies, meaning that a mutation could be more frequent in the lymph node compared to the blood, or vice versa. And that might suggest that the disease is not, freely circulating between the lymph node and blood. I think basically suggesting, what we already see in clinic, that some patients don't always necessarily progress in all the sites, but specifically more in, for example, the lymph node versus the blood. So.
Wow. Well, thank you so much. That is a lot of information, and clonal evolution is a very complicated topic, and the acquisition of new mutations is also pretty complex. Listening to your explanation, one thing that really struck me is that the people that were enrolled in your study had CLL that was very high risk, and yet acalabrutinib was really effective controlling the disease for a median of 6 years. So I think that's really encouraging. And then learning about the acquisition of new mutations, I wanted to clarify one question. Did every patient who developed a mutation to the BTK inhibitor ultimately have progressive disease?
So we actually could only detect the mutations in BTK in patients who eventually progressed. We have not found any mutations in those who remain in remission. So the answer is yes. I would say that in other studies, depending on the method and the sensitivity of the assay, there have been some studies that have shown that even in patients who remain in remission, sometimes these mutations can be detected, but eventually the pattern is that they outgrow and overtake the majority of cells and lead to progression.
And how do you anticipate that we'll be able to use this information to improve treatments for people who have CLL?
That's that's our kind of that's a really great question, and I think the identity when I think there's been a renewed interest in BTK mutations. Honestly, when when pirtobrutinib came around, the non-covalent BTK inhibitor, and seemed like a good option for patients progressing on ibrutinib. I think there became a new interest in understanding resistance patterns to pirtobrutinib. So that was, that came out, in the last couple of years, where there were new mutations outside of the C481 residue that appeared to be mutated in patients who developed resistance to pirtobrutinib. And then it was almost like going back and trying to understand what other covalent inhibitors do in terms of, leading treatment resistance mutations. So the specific one I had mentioned earlier, T474I, that mutation seems to confer resistance to pirtobrutinib because it's also been described in patients who develop progressive disease while being treated on pirto. So I don't think we're quite there yet, but gathering these data and trying to understand, what the selection of the covalent BTK inhibitor might influence later outcomes with therapies down the road. It's becoming more relevant now that we're trying to understand more of the resistance patterns. And same goes for zanubrutinib, right? The other covalent BTK inhibitor that's increasingly being used in patients with CLL. That also appears to have a different BTK kind of mutation pattern than ibrutinib. So in my mind, we're still in the kind of data collection phase, and ultimately what matters is how patients actually respond, right? We can kind of wave our hands about what we see in terms of mutations, but what the actual endpoint I think that matters is how long do the remissions last with these patients who have these mutations and are entering, the next treatment, whether it would be with pirtobrutinib or different non-covalent BTK inhibitor.
Thank you. So it sounds like we are in the data collection phase. We're learning a lot, and eventually we can use this information for selection of treatment, helping us decide selection of treatment and possibly even new drug development.
Yes, completely agree. Yeah, I think there are, other non-covalent BTK inhibitors that are in clinical development right now. Nemtabrutinib, as an example, seems to inhibit some of these other BTK mutants. So it may influence how we kind of select the next therapies as we understand more about the resistance patterns.
Wow. Well, thank you so much for being with us today and sharing this information with us. And I really appreciate your dedication to the field and working on this important research.
Thank you so much, Laura, for having me.